Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Intracellular Therapies, Inc.
Hello, I'm Dr. Leslie Citrom, Clinical Professor of Psychiatry and Behavioral Sciences at New York Medical College in Valhalla, New York. Joining me today is Dr. Joseph Goldberg, Clinical Professor of Psychiatry at the Icahn School of Medicine at Mount Sinai in New York. Welcome, Joe.
Thank you, Les. Pleasure to be here with you, as always.
So we're going to talk about the mixed feature specifier at some length today, but it is a little confusing because we've heard of mixed episodes for just so long. And when we look at the product labels of different medications, it seems that some products are approved for acute mania and mixed episodes. But what are those, and what's the difference between those and the mixed feature specifier before we get into our case?
Well, so let's be very pragmatic. In the DSM-4, a mixed episode meant a bipolar 1 patient who was syndromally manic and syndromally had a major depressive episode for at least a week. It turns out that's a pretty rare thing to see. It didn't take into account subthreshold features of one or the other state, didn't take into account bipolar 2 patients, didn't even take into account unipolar patients who had some features of mania. So the more modern DSM-5 conceptualization of what's been termed the mixed features specifier is a bit more broadly inclusive to encompass the presence of a full syndrome of a major depression with at least a few symptoms of the opposite pole. Or it can't even be vice versa. You could have a full-blown mania or even a hypomania with a few features of the opposite pole. The syndromal criteria of 1 week pertain to manias. If you have unipolar disorder, that means 2 weeks of depression with some low-grade symptoms on top. And if you have bipolar depression, again, it means you've got at least a couple of weeks of the syndrome of depression with at least a few of the mood elevation features. And it gets just a little bit crankier because you can't double count certain symptoms, which doesn't mean they're not relevant, but things like insomnia, which could be the loss of the need for sleep, or I just want to sleep, but I can't, or distractibility or irritability or agitation are examples of things that could go with either pole. So it's not that you just count those symptoms. The key takeaway, I think, from DSM-5 is it's not so persnickety as to say you've got to have the whole shebang of a full mania syndrome for at least a week. Even subthreshold symptoms count and are differentiable from, let's say, pure depressed states.
Well, it sounds a lot more useful because I would imagine those with the mixed episodes would be in the hospital and the treatment would be targeted towards their mania, which is very problematic. And kind of the depression is off to the side for a little while you control the mania. What about those with unipolar depression, major depressive disorder, who actually have a touch of hypomanic symptoms or manic symptoms? What do we call those?
Yeah, so that's another, thank you, DSM-5, for giving us that new concept meant to speak to the notion of a continuum of polarities. So unlike, is this bipolar or unipolar? The notion here is there are some patients with syndromal depression who've never had enough symptoms of mania and or for a long enough period of time to call it the syndrome of hypomania or mania. There's not a lot of research about what to do with this entity called major depressive disorder with mixed features, or MDD-MF. The best of studies, and there aren't a lot of them, says that when people with MDD-MF get followed over several years, about 1 out of 5 will go on to have a full visible syndrome of a hypomania or a mania. They get a membership card in the bipolar club at that point, but it means 80% don't. And so clinicians are left sort of having to think about practical things like, if I use an antidepressant for someone who's depressed with even a few symptoms on the high, would that exacerbate the high? And the answer is it might. It very well might. So that might be reason for caution. Also has implications for things like prognosis and course and outcome, suicide risk and things like that. So we don't know as much as we need to about MDDMF, but it is this more emerging concept that requires careful evaluation and monitoring over time.
Well, that's good to know. Let's dig into the case. We'll call her Ellen. She's a 21-year-old woman who presents with depression. She scores 20 on the PHQ-9, so that's not good at all. She has a history of one prior depressive episode 18 months ago and has been prescribed sertraline, but stopped taking it after only 1 month. She says the sertraline worked and she would like to receive it again, but she does appear somewhat irritable, has gone by with 4 hours of sleep per night, and has rapid speech. So what do you think, first impression here?
So lots here to boil things down. A 21-year-old woman with depression that's high severity with a prior depression at 19 or so is certainly in the prime time of life to have a mania or hypomania. Would love to know about family history and would love to screen for a lifetime history of mania or hypomania. In fact, some practice guidelines tell us that before you diagnose someone with depression as unipolar disorder or embark on the treatment for that, you ought to really screen for a lifetime history of mania or hypomania. So within a month of starting an SSRI, she seems happy with the result, and the observables are she's sleeping less, talking faster, more irritable. So this certainly could be the emergence of a hypomanic syndrome. The DSM-5 says if you stop the antidepressant and the symptoms then persist at a syndromal level, that equals bipolar disorder. But if the symptoms all go away within, say, 5 half-lives of elimination, then we might call this a side effect or an adverse effect. So even though Ellen seems happy with what she's taking, and perhaps she's experiencing an uptick in mood that's not necessarily euthymia, our challenge is going to be to say, I'm concerned that this may be having a deleterious effect on you. Let's stop the sertraline. Let's monitor your mood very carefully over the next week. If all this goes away, we'll start over. But if it persists per DSM-5, then we're going to have to re-diagnose this as bipolar 2 disorder if her functioning is not impaired and she's not psychotic, or perhaps even bipolar 1 disorder if it's really more severe than that. And last but not least, we have to keep a really close eye on Ellen, because if this is an emerging process, it could get worse and she may end up needing a more intense level of care.
What disturbs me about Ellen is that she's had 2 depressive episodes and she's relatively young. She was also prescribed sertraline, but took it for only a month. So to me, this is a big question mark, and I'd like to use some kind of screening tool. What about the rapid mood screener? What's that about?
So the rapid mood screener is 6 questions that ask about features that are consistent with the diagnosis of bipolar disorder, which includes things like adverse reactions to antidepressants in the past or a high frequency of occurrences of episodes. It maps pretty concordantly with a longer screen many people know, perhaps called the Mood Disorders Questionnaire, the MDQ, which I guess has become the gold standard self-report screen. It's a series of questions very key to the DSM criteria for mania. It's a little better in predicting or detecting mania than hypomania. And it's not a proxy for the diagnosis, it's a screen for the diagnosis, just like a pap smear is not a proxy for cervical cancer, but it's a screen to identify people of interest. So on the plus side, the RMS is very fast and easy to administer. And if you score 4 or 5 or 6 positively out of these 6 questions, it doesn't mean you have bipolar disorder, but let's just say you are now a person of interest and you need to have a more detailed and involved assessment.
So the rapid mood screener is relatively quick. It includes questions about depression, not just mania or hypomania. So it might be helpful for someone like Ellen. But I like personally the mood disorder questionnaire because there's a lot more questions about potential hypomania in the past.
Agree. And one thing that the clinician should keep in mind as much as the researcher is when you're screening. So think about this. You don't want to miss anybody. If I'm screening for cancer, um, I'd rather be over inclusive and call something a case when it's not, because the alternative, a so-called false negative, could be a disaster. So on the plus side, while the rapid mood screener is actually pretty sensitive to picking up all the cases, it's not specific. And you could have treatment resistant depression or psychotic depression or highly recurrent depression and not have bipolar disorder. So we don't want to overstate what a screener can do. We want to use it just for its intended purpose, which is to not miss anybody. But yeah, you're right. I think something like the MDQ, which is also a screener, gets far more granular and lets us get into questions about, well, the core symptoms of mania. And by the way, the mood disorders questionnaire is a pretty good interview format. We published a study some years ago showing if you take the patient's self-reported MDQ that they do in the waiting room and use it to go over their symptoms and get clarification, like, what do you mean by racing thoughts? Or what do you mean by decreased need for sleep? Are you tired the next day or not? It's got really good predictive reliability for making a clinical diagnosis. So it's a really excellent guide for following through to make a good interview.
I couldn't agree with you more. I think the mood disorder questionnaire, as well as the PHQ-9 that the patient fills out, it gives us, some stuff to talk about, and they're not surprised when we ask these questions. And when they fill out a form, it opens up an opportunity for greater discussion. That's what I find the most useful part about these screening instruments. And let's not forget about the PHQ-9. Also, I can follow patients over time with it, and they're familiar with it. And I find that helpful. Just my own personal opinion there.
I concur. It's also a good marker for change over time. So, my internist can measure my blood pressure or my cholesterol, or my pain doctor could measure my pain, or my eye doctor can follow my vision score and tell me things over time, like it's getting worse or it's getting better, or if there's been an intervention, how much has the intervention had an impact. So to tell, say, Ellen, oh, let's suppose we give her a different treatment because I don't think she's going to get sertraline again. We're going to have to explain to her why that's probably not a great
Well,
idea. And have,
well, should she get sertraline again?
well, technically, not if she's having irritability and decreased need for sleep and rapid speech. That'd be like any other adverse reaction. So the challenge here, potentially for the clinician, is if she likes the way she's feeling but doesn't perceive or appreciate it as potentially detrimental and something that could lead to negative consequences down the road, we may need to get her family involved. We may need to be able to have a contract or say, look, here's my concern. Let's track your sleep over the coming week. But at the very least, I think we're obliged to stop it and see if these things clear up. Because if they don't, then her diagnosis has changed. So, yeah, I think one would be hard pressed to justify continuing the sertraline.
Well, so you're an expert, Joe, and you know what to look for. And it's kind of hard when you're not used to seeing these patients on a regular basis and they come into your office. And we need some assistance here. Our mutual friend, Roger McIntyre, came up with his 4 A's as related to mixed features. Want to take us through that?
Yeah. So the A's that Roger and colleagues have talked about, anxiety, agitation, anger, irritability, and attentional problems, are kind of like fever and shortness of breath, in that you often see them and they're often there, and you'd be remiss to not pay attention to them as clues that someone who presents with depression isn't, quote, just depressed or purely depressed phase. The problem, though, is kind of like with the other things we discussed with screening, is these things aren't diagnostic or pathognomonic or specific. So you could have anxiety or agitation or irritability or attention problems for lots and lots of reasons. So the task for the clinician is not to say just, you have a fever, it must be an infection, or you're short of breath, it must be asthma, but to make note of these anxiety, agitation, anger, and attentional symptoms, and not sit back and say, this is just depression. These are like gateway symptoms that should prompt that more thorough assessment for all of the symptoms of mania or hypomania. And really the core of that is energy, right? So mania, DSM-5 tells us, is a disorder of increased energy and activity. You can't be slumped back in your chair with monotone, soft speech that's slow and tell somebody you're manic. The signs have to be there as much as the symptoms. And this, to me, is what really makes for the challenge of a careful diagnostic assessment, because the dividends pay off when you pick the right treatment.
So I use the 4 A's as just, keeping my eye on things that don't belong. And if things that don't belong are present, then I know I need to ask more questions. And I'm not dealing with plain vanilla MDD anymore. At the very least, I'm dealing with maybe MDD with some issues that actually are quite alarming, if not going right into the mixed feature specifier when I look deeper. So I find it kind of helpful just to jog my memory to be on the lookout for these issues of anxiety, agitation, anger, and attentional disturbance as a trigger for me to look a little deeper. Well, let's say Ellen is ultimately diagnosed as bipolar type 2 depression with the mixed feature specifier. What are the choices of treatment?
So let's think about this in two respects. One would be, what are the evidence-based interventions, pharmacologically speaking, for bipolar 2 disorder in the depressed phase? And there are two FDA-approved treatments for that very specific type of presentation. And then there are three others that are more broadly FDA approved for bipolar depression, either type 1 or type 2. And many of these have also been studied for the presence of mixed features. So let's comment on that in just a moment. But I think just the other step back panoramic perspective to take here is in mood disorders in general and bipolar disorder in particular, one does not want to myopically be thinking about how am I going to treat this episode in front of me without taking into some appreciation a slightly more panoramic perspective of how does this episode present relative to your past and your future. Despite the fact that of the 5 FDA-approved treatments for bipolar depression, they all are or contain a so-called atypical antipsychotic. So lumateperone, quetiapine, the combination uniquely of olanzapine with fluoxetine, and then lurasidone and cariprazine are all FDA-approved as single agents for bipolar 1 disorder. 2 and only 2 of these have the FDA's approval for bipolar 2 depression. That's lumateperone or quetiapine. Anything else is technically off-label. And then as an add-on to lithium or valproate, a couple of agents have FDA indications. That'd be lumateperone and lurasidone. And that's in bipolar 1 disorder. Lumateperone has its indication as augmentation in bipolar 2 as well as bipolar 1 disorder.
So what you didn't mention are antidepressants like sertraline. They are not approved for bipolar depression, and we are always worried about making something worse. Let's put a final nail in that coffin.
Well, what I'd say to a patient is, sort of what's in a name? The name antidepressant carries implications of what it's going to do. And monoaminergic antidepressants, SSRIs like sertraline, do treat unipolar depression. But if I was the patient, I would really want my healthcare provider to share the following information with me. Ready? This thing that's been shown to treat a different kind of depression has never been shown to work for yours before. So before we give you a treatment that aims to treat an ailment that could be life-threatening, as many as 1 in 5 or 1 in 6 people with bipolar disorder attempt or complete suicide. As many as 1 in 2 actually attempted, particularly in mixed features presentations when there's that energized state superimposed on the despair and hopelessness. How would you feel if your healthcare provider said, well, let's give you something that's never been shown to work? So antidepressants have 2 main risks. One is the chance that they could induce or exacerbate mania symptoms, and that's been shown to be especially the case if you have even low-grade mixed features to start with. I like to say that's sort of like striking a match when the room is filled with gasoline fumes. They will ignite. And most people with bipolar depression, it turns out, actually do have at least some mixed features. It's pretty rare to see just pure depression without signs of speediness or sleeplessness going on. But the second risk is even bigger than the risk of inducing or exacerbating mania or hypomania, which is they've never been shown to work. And again, if I was the patient, I would be very unhappy if my healthcare provider didn't share that information with me. I'd like rather to be offered things that have been shown to work better than a placebo and have a large evidence base behind them.
Yeah, so what could happen is it simply doesn't work, and that's not good. But what's even worse is the induction of mania, because we know mania is associated with all sorts of consequences, and someone can lose their home, their family, their friends, their credit rating, you name it. Well, let's say you're treating someone with bipolar disorder in the maintenance phase of their illness, and they're on a mood stabilizer. Let's say they're on lithium or valproate, and we want to just avoid depressions. And some have really believed quite intensely that adding an antidepressant is not harmful as long as a mood stabilizer is on board. Does that antidepressant add any value? So, what does Step BD tell us about that?
Step ED says you're wasting your time. Adding an antidepressant does not deliver a greater benefit than a mood stabilizer alone. In that study, we found about 1 in 4 syndromally depressed bipolar patients became meaningfully improved with a mood stabilizer, such as lithium or valproate, regardless of taking an antidepressant. The antidepressant added no benefit. And that study actually sort of led us to look into these sort of more fine-grained issues of other subtypes for whom antidepressants make things worse. So when I say 10 to 15% can induce into mania, it's a higher risk if you're bipolar 1 with mixed features and rapid cycling and a prior history. It's a lesser risk if you don't have those elements. But no one, I think, has ever shown here are the earmarkings of a good response to an antidepressant. And a good response to an antidepressant in some studies, well, none has ever beaten a placebo. In some of the work that the Stanley Foundation did, response rates are anywhere between 9 and 30%. So I ask you, Mr. or Miss Patient, do you want to take a treatment that's got like a 9 to 20 or maybe 30% success rate when there are other things that could work better? I mean, as we appeal to patients, just, what are their goals and wishes? You're really gambling with an antidepressant, with one exception. If Mr. Jones clearly got better with this, evidence-based medicine says he should get this. It worked for him if there's no ambiguity. Personal history counts for a lot. It's just I now can't generalize to the next person who walks through the door and say, well, it was good for him. Maybe it'll work for you. So things can be idiosyncratic, but that's more the exception than the rule.
Yeah, it's more the exception than the rule. I think we need to really keep that in mind when we think about antidepressants. We've all had patients who seem to do better with an antidepressant. They seem to do worse when we take it away, and then they get better again when they're on the antidepressant. That's a different situation. I totally agree. So let's go to the evidence-based and FDA-approved treatments. We have 5 of them. That's it, just 5. I wish we had more, but 5, and they all have the second generation antipsychotic as its base. The only weird one out there is lansoprazole fluoxetine combination, but the others are monotherapies, and how they were tested. 2 of them were also looked at adjunctively with lithium or valproate. My question is, how are they different in terms of tolerability?
Before I ask you to answer your own question, Les, let me ask you this. Is it fair to say that when you're comparing these 5, and there are no head-to-head comparisons, no one has looked at lurasidone versus, say, lumateperone, and in fact, these are all drugs that have fairly meaningful clinical impact. So if there are differences to be seen among them, they're likely going to be nuanced or based on adverse effects and tolerability, or maybe what would be called non-inferiority, which is to say no one is worse than another, and they all perform to a certain level of expectation in terms of benefit, but that their differences largely lie on, tolerability, and I was going to say also maybe other aspects of treatment. For instance, some of these agents can treat mania as well as depression. Quetiapine and cariprazine have what we call bimodal efficacy. They work on both poles. Some have only been studied for the depressed phase, such as lurasidone or lumateperone. All have pretty much been studied in the setting of mixed features and have not been shown to exacerbate mania symptoms, and can also reduce low-grade mania symptoms. So that's very encouraging. But when it comes to tolerability, to your point, you have kindly helped the field out, I think, by developing what you termed a heat map of tolerability. That is to say, how many people here, I'm going to see if I can explain less citrome to less citrome. How many people do you have to expose to a treatment before a particular adverse event of interest is more likely to be seen as one additional case? May I ask you, Les, to help us understand how to interpret the heat map?
Sure. So I calculated the number needed to harm for a variety of different adverse outcomes. And what number needed to harm is, it answers the question how many patients needed to be randomized in the clinical trial to the drug of interest versus placebo before expecting one additional case of that adverse event you would rather avoid. So the larger the number needed to harm, the better, because you will encounter that adverse event less frequently. Now, we can have number needed to harm values less than 10, which means it took less than 10 people to be randomized to the drug of interest versus placebo before expecting to encounter one additional patient with that problem. So that will be pretty common, and in day-to-day practice, you will encounter it with some frequency. And so the kind of poster child of this, and there are two of them, is weight gain of at least 7% with olanzapine fluoxetine combination versus placebo. The number needed to harm is 6. For every 6 patients randomized to OFC, as we call it, versus placebo, you would expect one additional patient with weight gain that is rather excessive and unwanted, at least 7% from baseline. It so happens that that's pretty close to the number needed to treat value that we would expect response or remission, which are good things. We're equally likely to see both. So that's a problem, right? And in terms of quetiapine, somnolence has a number needed to harm of 3. For every 3 patients randomized to quetiapine versus placebo, pooled together from all the trials, for every 3, you would encounter one additional patient with a complaint of somnolence. And no one wants to be tired and sluggish and slowed down when they're being treated for depression. And it turns out that you'll encounter that more often than response or remission. So that's a problem. Fortunately, the 3 newest agents, cariprazine, lumateperone, and lurasidone, in no particular order other than kind of alphabetical, are more, tolerable in general. So you can have number needed to harm values between 10 and 19, and to me that represents intermediate risk. Or you can have a number needed to harm of at least 20, which tells me, I'm probably not going to encounter this all that frequently. And so I color coded these number needed to harm values in a heat map, with red for NNH less than 10, higher risk, yellow for NNH between 10 and 19 for intermediate risk, and green for NNH of at least 20, which represents lower risk. With cariprazine, lumateperone, and lurasidone, we see a sea of green, as we say, and especially at the lower dose of cariprazine, 1.5 milligrams a day, and for the lower dose of lurasidone, the range of 20 to 60 milligrams a day, and in general for lumateperone. However, there are some yellow in here, so akathisia with cariprazine at the higher dose, the NNH is 13. Somnolence with lumateperone, the NNH is 10, and akathisia with lurasidone at the lower end, it's 18, the NNH, and at the upper end, it's 12, along with nausea at the upper end, an NNH of 11, and 14 for somnolence, and 16 for motor movements in general. So, but we have certainly a lot better tolerability for most cases with the 3 newest options. So I find number needed harm quite helpful. It's easy to calculate. It's beyond the scope of today's discussion, but it is so simple, even I can calculate it. And I go through these calculations whenever I talk about it in greater detail. So thanks for the opportunity, Joe, to talk about my favorite subject. Well, let's get back to Ellen. Ellen was given sertraline. She asked for sertraline. It's hard to say no to a patient who asks for something and, you're in a hurry and, okay, it's MDD and she wants it and, she becomes manic and then she's in the hospital. What happens then?
A lot. So look, we can't predict the future, but if I were Ellen's clinician and she was insistent on the sertraline, I would probably want to make sure that I've had a documented discussion with her about the risks, and that, if this is emerging mania, things could go really badly. This is an outcome, and we have to be following her closely. So, whatever you do with Ellen, you keep an eye on her. You don't say come back in a month, and you probably want her family involved, or you want to know her emergency contact, so that nobody comes back and says, could this have been avoided? However, it is what it is. And so Ellen has now declared her biological vulnerability to mania, full-blown mania, which let's assume persists. For heaven's sake, at this point, please stop the sertraline. Do you know there was a study out at Yale that showed if you hospitalize manic patients who are on antidepressants, merely stopping the antidepressant alone and stabilizing their sleep-wake cycle is actually beneficial. So in this rushed clinical environment we all live in, where you got to do something today, and in a more perfect world, one might say, just what happens if you've removed the catalyst? Now that could be very hazardous, because if I remove the match, the fire is still there, and now I get to say, aha, the match was a catalyst, not a cause, and say to Ellen, okay, Ellen, you have bipolar 1 disorder. It led to hospitalization. And now everything is going to change for you in terms of understanding your illness, its course, its prognosis. So what happens for Ellen now? She's in the hospital. Please, please, please stop the antidepressant. More than likely, we need to start a medication to treat the mania and get it under control, so that we can then move her into the outpatient realm and prevent relapse. A million questions are going to then arise. Does she really have a lifetime illness? Many would say, yeah, especially if the mania symptoms persisted off the sertraline. That's declared her biological vulnerability. Could it get even worse? You don't just want to throw a low dose of an antimanic drug at her and send her on her way and back to work on Monday, only to find out, as you said, catastrophic things can happen. And the average mood episode in mania does not last days, it lasts weeks. In the NIMH collaborative study,
that's disturbing, isn't it? And as I worked inpatient for most of my career with a variety of settings, and I would see the patient, a couple times a day, maybe in group, but the person or people who are with the patient 24/7 are the direct care staff, including nurses and therapy aides and so on. What information can they provide that is useful? It's a rhetorical question.
Yeah, well, no. So if there's a silver lining to her being hospitalized, I guess there is, if she's sort of on the fence about my concerns that she could have bipolar disorder, here's an opportunity to galvanize diagnostic impressions. Nursing staff are critical members of the inpatient team in making careful observations about how the patient is sleeping, behaving, thinking, interacting with others, their attitudes about treatment, accepting medication, how they respond in groups, how they're talking about really the life transition that goes on. You've just received a new diagnosis that can have lifelong implications. Providing psychoeducation, I would say the nursing staff is actually critically pivotal, if that's not redundant, in terms of helping someone like Ellen through this process. It's not so simple as to say, here, take your antimanic drug, you're dischargeable within 5 to 7 days, and then off you go with fingers crossed. So this is a transformative moment in Ellen's life. It's going to be getting next of kin and family members involved, caretakers involved, bringing Ellen's knowledge base up to speed with resources about how to care for your illness. And this is not something that's usually done in the short term. It's an ongoing process. And I think that, it takes a village. The team approach is important, and the nursing staff is pivotal in keeping all the elements integrated.
In some respects, Ellen was lucky. She was re-diagnosed accurately after a relatively short period of time. And I say this because the average length of time where someone goes about with an MDD diagnosis can be 5 to 10 years. 10 years, if you have bipolar type 2, is very common because we don't ask the right questions. And patients don't necessarily have the insight as to report them. So I find the screening tools that we talked about very helpful in having this conversation. Well, Joe, that was a wonderful discussion about the differential diagnosis and treatment of people with bipolar depression with the mixed feature specifier. We focused on that, and I look forward to future discussions.
As do I, Les. Thanks so much for sharing your knowledge and your wisdom with us, and We hope you've all found this helpful. Hope to see you again soon.
And thank you for participating in this activity. Please continue on to answer the questions that follow and complete the evaluation.